How you doing, everybody? This is Dr. Barakat Thabit. I'm gonna do the cardiology for the cardiac arrhythmia, and always remember the Shersheli B on let T of Mario. We're gonna start first of all with the sinus tachy. We have two persistence, the NST and IST, and we have two paroxysmal, which is the POTS and the SNR ET. Treatment of sinus tachy, of course, will be addressing the basic underlying stressor. The sinus brady, on the other hand, take many forms, but the most common form is the inferior wall MI. Other form, physiological, sinus syndrome or sick sinus syndrome, the SA block, and atropine should be the drug of choice. If the SP in patient with SS was followed by proximal of tachy, this is called the Brady-Tachy syndrome. AF, which is the most common arrhythmia, age dependent, and we have three types: the paroxysmal, persistence, and the permanent, and heart rate usually between 3 to 600 beats per minute. The Chad's index uses the point system to determine yearly thromboembolic risk. That's why anticoagulant used to prevent thromboembolic complication in AF. AFL, on the other hand, the atrial rate of 250 to 350 due to a macro reentrant right atrial circuit and maybe transit rhythm that progresses to AVF, and the characteristic sawtooth would be a characteristic. The MAT 3 or more P wave morphology, common in chronic lung disease, and magnesium therapy may be sometimes effective. Note that JET and the NBJT are rare but common in children following congenital heart disease. Next one is the EAT, which is the most common form of insistent SVT in children, and most patients diminishing first and second degree AV block, and this is called a TEC, causes TEC or the tachy-induced cardiomyopathy. The PAC, which is occur before the next normal P wave, compensatory pause often follow, and is considered as the forerunner for other arrhythmias such as AV and RT. Note that sudden run of 3 or more premature SV beat constituted for PSVT, and we have three types of PSVT, which are the AV and RT, AVRT, and unifocal AT. First one is the AV and RT, which is the most common type of PSVT triggered by a PAC. PR interval is longer than RP. That's why P wave is usually get at the terminal portion of QR, and the heart rate ranging almost 150. To terminate an acute episode, men are given the adenosine, which is the pharmacological cardioversion, and drug used to prevent recurrence are given oral, which is the beta blocker, calcium channel blocker, and DIC. The AVRT is the second most common form of PSVT and associated with epistem anomaly, and patients with AVRT are at risk for developing a sudden cardiac death. The short PR, delta wave, wide QRS, all considered for WBW syndrome, but not in long Gannon-Levin syndrome. There is no delta wave. Note that orthodromic AVRT is the antigrade AVN, while the AP is retrograde, and in the antidromic is the reverse. The reverse is correct, and adenosine and other AV node blocker should be avoided in AV or AFL with pre-excitation syndrome. The AT, which is the unifocal form, defined as 3 or more PACs, heart rate between 100 and 250, and a short episode may require no therapy. The long QT syndrome, very important subject, will be defined as a QTC longer than 0.44 seconds, lead to polymorphic VT, which is the torsati point. The VF and SCED beta blocker are the prerequisite, and ICD to prevent SCED. The long QT syndrome has been recognized in Romanov syndrome, which is autosomal dominant, and Gerver and Lang-Nielsen syndrome, which is autosomal recessive, and the characteristic congenital deafness, arrhythmia, and long Q account for the E syndrome. Acquired long QT syndrome, electrolyte disorder, hypokalemia, magnesemia, drug-induced imidazole, sotalol, TCA, and it's can happen with first episode of syncope in about 30% of patients. Note that reactivation of calcium channel or decrease outward potassium current that result in early after dipole, which is in turn lead to polymorphic VT or torsade de points, suppression of the early after dipole by magnesium, or increase the potassium concentration to high A normal. VF dipole during the early phase of repole, or what's so called the RNT phenomena, may lead to initiation of VF and treatment, of course, by electronic defib, epinephrine, anti-arrhythmic drugs such as midodrine and lidocaine. The VT, in which the monomorphic is the polymorphic, the CAD is the most common setting for VT, and of course treatment by electrical defib for unstable patient, anti-arrhythmic imidazole, and lidocaine. And of course, endocardial catheter ablation is used to treat symptomatic VT rather than a decrease in SCAD risk. Heart block are three main types: SA block, which is Mobitz 1 or SA Winkeback, Mobitz 2, and SA node exit block. While on the other hand, AV block have the first degree, the second degree or Mobitz 1 or AV Winkeback, and third degree. The last one is the infrahessian block, the second degree AV or the Mobitz 2 or non-Winkeback AV block, the LPP, RPP, and note that AV Mobitz 2 may produce a stacked Adams syncopic attack. Thank you very much.